Theoretical and practical questions of the non-invasive measurement of arterial stiffness. Part 7. Validations. The most important paper among the validation studies was published in the Journal of Hypertension in 2010. In this paper, Ivan Horvat and co-workers pointed out that the augmentation index, central systolic blood pressure, and aortic pulse velocity measured oscillometrically with arteriograph showed strong correlation with the invasively recorded counterparts. The observed limits of agreement were encouragingly low for accepting the method for clinical use. Their results suggested that the aortic pulse velocity values measured by arteriograph were closely related to the true aortic pulse velocity determined invasively. In another paper, Johannes Ballmann and co-workers showed that the variability and reproducibility for pulse velocity were best for arteriograph compared to tonometric sphygmochore and piezoelectric complier method. Marek Reiser and co-workers pointed out in their paper published in the Journal of Hypertension in 2008 that no differences were noted between pulse velocity measurement using sphygmochore and arteriograph. For clinical point of view, the most important study was presented on the 23rd European Meeting on Hypertension and Cardiovascular Protection in Milan. It was pointed out that the aortic stiffness measured by arteriograph by a novel osteolytic method independently predicted cardiovascular morbidity and mortality in a large cohort which was consisted of more than 4,100 subjects. The main outcomes of the trial were: the mean follow-up was more than 5 years. Primary composite endpoints were altogether 241, which consisted of all-cause mortality in 100 cases, non-fatal acute myocardial infarction 56 cases, and non-fatal stroke 85 cases. Other events were also recorded, but were not taken into account in the statistical analysis. The results are: the risk prediction for the primary composite endpoint, which was all-cause mortality, non-fatal MI, and non-fatal stroke, the univariate analysis showed that 1 meter per second increase in the aortic pulse velocity measured by arteriograph equal to the increase of the risk of the composite endpoint with 49%. Using multivariate analysis, aortic pulse velocity turned to be independent predictor of the primary composite endpoint. The secondary endpoint was the all-cause mortality. The univariate analysis showed that 1 meter per second increase in the aortic pulse velocity resulted 71% increase of the hazard ratio of the all-cause mortality. Using multivariate analysis, aortic pulse velocity turned to be significant, independent predictor of the all-cause mortality. Concluding the validation papers and the clinical study, we can say that the arteriograph measured arterial stiffness parameters. Indeed, they are accurate compared to the invasively and non-invasively measured counterparts. Furthermore, which is most important, arteriograph predicts and arteriograph pulse velocity predicts the future unfavorable cardiovascular outcome, such as composite and endpoint and all-cause mortality as a secondary endpoint. Thus, if we can find elevated aortic pulse velocity measured with arteriograph, we can conclude that this increased value is equal to the proven increased cardiovascular risk of composite endpoint such as all-cause mortality, non-fatal MI and stroke, and for the all-cause mortality as a secondary endpoint. Thank you for your attention.